We are happy to launch the first session of our webinars called Glucomatology. The idea of these webinars are actually there since the beginning of this lockdown, which the whole world passed through. And the Egyptian Society for the Glaucomas, we wanted to make something more comprehensive in the flow and the big sea of the webinars all over the world. We wanted to make something very comprehensive. And the idea actually started with Professor Ahmad and myself talking and discussing this idea. And then we had the support of Orchidia, this huge pharmaceutical company, which had a similar thought to continue their Great Minds sessions, which started a few years ago. So both combined together, and in the past few months, we have been heavily working on these to produce these chain or these episodes, which would last probably till early December, inshallah. This is the first one, and it is about examination. And we are very honored actually to have our dear friend from London, Miss Winifred Nolan. She is an excellent friend, and she is a supporter of the Egyptian Society for the Glaucomas. And she was one of our main guest speakers in the 2019 edition. Welcome, Winnie. Thank you for joining us. We know it's a very precious time for you, but I'm sure we are going to get a tremendous benefit from your talks. We are also honored by having our national speakers, Dr. Amanne F Esmael, Dr. Reham Samy, and naturally the scientific coordinator of this whole activity, Professor Nader Bayoumi from Alexandria. Dr. Nader, I think, please, you can take over now.
Yes, sir, I'm ready. Okay, so Engineer Ali, do I proceed?
Yes, please.
So, good evening, everyone. I would like to welcome all our participants and our panelists, and I just hope that we manage to introduce or deliver to you a useful, fruitful message in this very beginning of our series of webinars. So, my talk is going to be a brief introduction about gonioscopy, and I will be discussing these topics. Just a moment. Okay, I will be discussing these topics: when to perform, so what are the indications, and when not to perform gonioscopy, which lens to use, how to perform, and just a brief slide on how does the normal angle look like. So, as a general ophthalmologist in a general ophthalmic practice, gonioscopy must be done if any part of the clinical sheet suggests any type of glaucoma, starting from the history, passing by the examination, and then the investigations, whether the complaint is visual or non-visual, anything suggesting glaucoma, colored highlights around light, visual field defect, pain, headache, attacks of redness in the eye, anything that suggests glaucoma. There are relative contraindications, not actual contraindications, but relative, if the patient demonstrates discharge for fear of cross-infection, and if there is a recent ocular surgery for fear of ocular integrity or the introduction of infection into the eye. So, which lens to use? Broadly speaking, we know that we have two types of gonioscopy lenses, generally speaking. There is the Zeiss model and the Goldman model. There are different varieties of these two, but the main differences being that the Zeiss model does not need a coupling fluid being flatter than the surface of the cornea, and the Goldman model needs a coupling fluid being steeper than the surface of the cornea. The former, the Zeiss, enables us to perform dynamic or indentation gonioscopy, while the Goldman does not allow us to perform indentation gonioscopy. So the technique is simple. We need to examine in semi-dark room, instill topical anesthetic in both eyes, and most importantly, educate the patient on what to expect. Mild pressure, cold sensation, a little bit of overflow on the cheek and no pain. Use the opposite hand to hold the lens, and always try to be seeing binocularly to appreciate that most of the time. So we start by instilling topical anesthetic in both eyes, right and left. You hold the handle or the lens according to the design of the lens you're using. Approach the cornea from slightly below center to avoid provoking the menace reflex and the patient closing their eyes immediately. Pose to the cornea, that is, touch the cornea by a gentle upward sweep of the upper lid, taking the lashes and the upper lid with you. Touch the cornea with the correct amount of pressure, no undue pressure or no less pressure. maintaining your pressure on the center of the cornea. As we can see here, this line, as we can see, denotes an improper contact with the surface of the cornea. This should not be present. And at the same time, if you focus on this mirror, as you can see, there are wrinkles on the surface of the cornea. Again, these should not be present, indicating the improper amount of pressure on the cornea. Once you've apposed your lens with the proper amount of pressure, just examine the mirrors serially with whatever order. Just make sure you check all 4 mirrors, superior, inferior, nasal, and temporal, so that you cover all 360 degrees of the angle. Now, moving on to the Goldman model, which necessitates a transparent viscous fluid, just half fill the lens cup with transparent viscous fluid, and just prepare a sheet of soft tissue to wipe the excess flow on the cheek. Because if you underfill the lens there, an air bubble would be present in the interface, and this air bubble would not permit proper examination. And if you overfill, there is going to be overflow on the cheek with smudging during the examination. This would not be comfortable for the examiner or for the patient, of course. So again, we hold the lens with one hand and gently invert the lower lid with the index finger of the other hand. We oppose the lens. We approach the eye from slightly below center and insert the lens rim onto the inferior fornix with the patient looking up. Of course, we instruct the patient to look upwards. Gently press the lens on the surface of the cornea with the patient still looking upwards. And with the lens opposed to the ocular surface, ask the patient to look forwards, and you're all set to examine the all 360 degree of the angle. Now let me finish this very simple introduction by just a picture of, let's say, a normal or standard angle, and the structures are simply the first line, which is the Schwalbe's line, followed by the first zone, which is the trabecular meshwork, followed by the second line, which is the scleral spur, followed by the second zone, which is the ciliary body, slate gray or pink coloration, and then the peripheral iris. Now, with this appearance of the normal angle, I conclude my presentation, and I hand on the mic to our honorable guest speaker, Ms. Winifred Nolan from Moorfields, to deliver us her excellent talk about anterior segment imaging and the details of gonioscopy. So please, Ms. Nolan, take the lead. Thank you very much.
Thank you. So I'll just try and share my screen. Okay, can you see that?
Yes.
Yep. Okay.
Yes, it's okay.
Okay, thanks very much for inviting me. And it was quite nice when we were waiting for other people to come on to hear the traffic noise of Cairo. It brought me back to when I visited there last year with all the busy traffic. So I'm going to, that was a nice introduction from Dr. Nader. And so I'll continue and talk about gonioscopy and imaging, particularly with an emphasis on looking for angle closure, because that's probably what we use these techniques for most. But I'll also just talk about what you do before that. So checking the anterior chamber depth is quite useful for, firstly, as a method maybe of case detection for people with angle closure, and also for getting an idea about mechanisms as well. And the peripheral limbal chamber depth is probably the most useful, because you can sometimes miss angle closure if you just look at the central anterior chamber depth. And for those of you who are not familiar with this, this is looking at the most peripheral part of the anterior chamber when you get at the sclerocorneal junction, and measuring the depth of the anterior chamber, which is between the posterior corneal endothelium, the iris anterior surface, as a proportion of the corneal thickness. So you need to shine the beam of the slit lamp perpendicular to that quite high magnification. Traditionally, this was termed the Van Herrick, and there was a 4-point scheme. But Paul Foster, when he did his population-based survey in Mongolia, refined this and concentrated more on the shallower end of the spectrum. And something I always remember from his work is that 99% of all narrow angles in that population were detectable using a limbal chamber depth grade cutoff of 25% or less. So it's quite a good method of case detection before you do gonioscopy, or for people who can't do gonioscopy, such as nurses. And you can also look at the rest of the anterior chamber. So this is an example of a very shallow peripheral anterior chamber, but deep central chamber and a flat iris. So again, if you just looked at the central AC, you would miss the angle closure, but you can see that peripherally. And other end of the spectrum, you have quite a shallow central and mid-peripheral anterior chamber, and that's due to a lens mechanism, usually quite a small eye. So gonioscopy gives us a 3D visualization of the angle, and also allows us to see other abnormalities such as pigmentation, appositional and synechial closure. And as already discussed, we have the Goldman lenses, which give you a stable view of the angle and are good particularly for people learning gonioscopy to get a good view of the angle and not inadvertently indenting it. And the MagnaView is very nice because it gives you a high magnification view of the angle. And then the 4-mirror gives you a nice rapid view of the whole angle and allows indentation. So I think we've heard about this already. I would just emphasize maybe use a small light beam as well that's not crossing the pupil so that you don't inadvertently open the angle. And I would tend to look at the superior and inferior quadrant first, offset the beam to the side, and then I would rotate the beam so you have a horizontal beam and offset that so that you get a slice through the nasal and temporal angles. And this is an example of an open angle where you can see all the structures, and a closed angle where you can see no structures. And the first thing you want to do really when you're doing gonioscopy is work out if the angle is open or closed. So a good way of doing this is establishing a landmark, because as with any technique, you can probably get away with a not very good technique most of the time, but in the difficult cases, it'll let you down. So it's good to have a tried and tested technique. And what I do is identify Schwalbe's line, because I know that Schwalbe's line is anterior to the trabecular meshwork. So once I've identified that, I can work backwards. And to do that, you need a narrow beam offset so that you get the apex of the corneal wedge. So this is the corneal epithelium, endothelium, and this is where they meet. That's Schwalbe's line. So we know trabecular meshwork is here, and this is ciliary body and scleral spur. And that gives you a lot more information than a broad beam, where sometimes you may have a pigmented angle or a very unpigmented angle, and it can be misleading sometimes in determining whether the angle's open or closed. And that's just a drawing showing the same structures. So this is an interesting example, very abnormally pigmented angle, but it's open. And you can see that because you have the apex of the corneal wedge, you have Schwalbe's line, and the angle is open. You may think that was closed if you just did broad beam gonioscopy. So that's why it's important to do this. It is abnormal, but it's not angle closure. It's an other abnormality of pigmentation. Some other examples. So this is the inferior angle. We're looking here, and generally all of this I would do in primary position. I can't see the apex of that corneal wedge. That means I can't see Schwalbe's line, which means I can't see the trabecular meshwork, so it's closed. And we define that closure as no visibility of trabecular meshwork. In another, there's some pigmentation on the angle. It's not pigmented trabecular meshwork, it's a dusting, granular dusting of pigment in the inferior angle. And again, you might be deceived and think that was trabecular meshwork, but it's not. It's around the level of Schwalbe's line, and the angle's open and visible behind that. And this is a nasal angle. And again, this is it's quite a pigmented iris, but a very unpigmented trabecular meshwork. So again, to the inexperienced eye, people may say, oh, those are PAS and it's closed and that's the trabecular meshwork, but it's not. This is trabecular meshwork and it's wide open. This just shows the level of illumination that you should be using to minimize inadvertently opening angle. And once you've established when the angle's open or closed, if it's open, you can get an estimate of the angle width, which we measure in degrees. And that's taking a tangent from the peripheral 1/3 of the iris and the angle wall and estimating that. And that sounds difficult, but if you practice, you get used to it. And you can also comment on the curvature of the iris. Is it steep or is it a plateau configuration? And sometimes they may have an abnormal iris insertion or PAS. So the space classification is and grading is quite comprehensive. And this is why I think it's beneficial to measure the width of the angle. This is a wide open angle. I can see all the structures. This is open but quite narrow. And I would measure that as 10 degrees, which when you record that means it's narrow, it's not closed, but I need to keep a check on this angle. So dynamic gonioscopy is useful if you want to open up the angle, and you can do that with the MagnaView, increase illumination, ask the patient to look towards the mirror, and then you can press a little bit on the cornea. If it's not opening up at all, then you can use the foremirror. And you want to here see what the dynamics of the angle opening and closure is. And you also want to look for abnormal pigmentation and synechial closure, which is important in definitions of glaucoma. This is an example of an angle seen with a MagnaView. Seems to have a slightly uneven insertion, a lot of pigmentation. Looks like PAS. You can indent it open in areas, but there is still PAS, so you get a good idea of how much is permanently closed. PAS can come in different shapes and sizes, and I'm sure you see quite a bit of it in Egypt. This is a high-rise, I call it a high-rise PAS. It's typical of pupil block, high closure and apposition between the iris and the angle wall, sticking there, and a broad base. This is more subtle, where you have the iris creeping up the angle wall, and you can see some trabecular meshwork, but there is PAS, which are more involved circumferentially. So a different mechanism, maybe more of a plateau mechanism. Iris processes are normally not pathological, and they're normally not distorting the angle or the iris, and they're lacy and fine and dendritic, whereas PAS are distorting and are pulling the iris, and you typically have a broad base and a narrow apex. And pigment in the superior angle is another sign of established angle closure. And pigment is one stage between apposition and synechia, where pigment is being left behind by that intermittent closure. And this is an example where you have someone with PAS, and at the same level you have that pigment. So pigment in the superior angle, when you're not seeing it elsewhere, associated with iridotrabecular contact, is by definition primary angle closure rather than just a suspect. And this is how you might record your findings. Just beware, there are other things to look for in gonioscopy. This is a patient with pigment dispersion, very heavy pigmentation. And obviously there's things like angle recession and neovascularization. So then if we move on to anterior segment imaging, this is useful in quantifying and angle parameters and anterior segment parameters. And it's given us a lot of information about mechanisms of angle closure, which can be helpful in planning treatment, though the recent trials kind of suggest taking the lens out works if you have established disease, regardless of mechanism. But there are some less straightforward cases. It's useful to have this documentation. And it's increasingly providing a role in detection of angle closure, but more screening out patients who are coming through our screening clinics at Moorfields. There was a lot of excitement about it being used as a screening test in Asia. Nothing's happened so far. So UBM is the traditional imaging that was developed in the 90s. It was initially quite cumbersome, and the patient had to lie flat with a saline water bath on their eye, and this transducer is brought down to do the imaging. The devices are a lot easier to use. Everything's incorporated into the handpiece. And it's a good way of looking at particularly the ciliary body, and has given quite a lot of information about mechanisms of angle closure. And so this is the classification that's been developed for quite a long time. And these are some UBM images which look at these different mechanisms. Pupil block, the commonest one with that forward bowing of the iris. Non-pupil block, so no forward bowing, quite a flat contour, plateau configuration and a bulky ciliary body. Lens, shallowing of the anterior chamber, post-iridotomy, and other more unusual cases like aqueous misdirection or choroidal effusions. So that's a kind of front to back approach to mechanisms. And just again, if we go back to those deep anterior chambers, but shallow peripherally, and that might be plateau iris, and it could just be that the iris dilates into the angle. It could be that they have a bulky ciliary body. And in the ZAP study, which was conducted in China, they did a lot of UBMs on all their patients. And so they found these variants of that term plateau iris, and they would probably all look quite similar on gonioscopy. But here you can see there are some differences. So this is maybe what you'd call a fairly classic plateau, so that forward angulation and then deepening of the anterior chamber, no ciliary sulcus. This patient has a ciliary sulcus, but they have quite a bulky peripheral iris, which when the pupil dilates will close off that angle. And this patient has a very bulky ciliary body. So when you try and indent this angle open, you'll get a double hump sign. You won't be able to indent that open very easily, but it won't look like PAS. It'll be kind of like a roll, and then it deepens, and then you've got another hump for the lens. They also looked at pre and post iridotomy and tried to establish why some angles open up and some don't. And these are both examples of before and after iridotomy. This angle's opening up, this one is not. And it's a combination of things, a bulky iris, shallow chamber. But I think what's quite interesting here is where the iris is inserting onto the ciliary body. It's really quite high up in the angle. It's more like mid-ciliary body here. So that's not something you can do much about. Anterior segment OCT is probably more user-friendly, and we don't really use UBM that much anymore, though it's useful for looking at ciliary body and looking for tumours and things behind the iris. And we originally had time domain, which was used for a while, and we now have spectral domain, which we commonly use in our clinic, and then swept source, which is a very nice Cassia machine that can give you a three-dimensional view of the angle. And as you probably know, this is OCT technology adapted for the anterior segment. It was developed for refractive surgery, and looking at the angle is a beneficial byproduct for us glaucomatologists. It's got the advantage of being non-contact and fairly easy to do, so it doesn't require as much experience or skill as UBM. And it gives you, again, nice recordable images and cross-sectional images of the angle. And this is an example of the angle anatomy that we see in angle closure. You can see scleral spur, which Schwabe's line, although that's our landmark for gonioscopy, is not always so easy to see on imaging, whereas scleral spur is better. And so you know that anterior to that is the trabecular meshwork, so this apposition shows closure. And you can see how the pigment on the posterior aspect of the iris is blocking the infrared light from getting through, so you don't get the view of the ciliary body that you do with UBM. There are quantitative measures. There's lots of quantitative measures of imaging, which look at the angle width in degrees. The angle opening distance is one that's quite often used in research, and that is if you take scleral spur and you measure a distance, 500 microns or 750, and then drop it perpendicular to the iris, and that is the angle opening distance. So that seems the most repeatable of all the measures. We don't use these very much in clinical work, but they're useful in research. One of the problems, though, certainly originally, was that it could be quite difficult to identify scleral spur, which is the landmark that you need to do these measurements. And this is an example from one of the time domain OCTs, showing in narrow angles it can be even more difficult. So in the light you can see scleral spur reasonably well. In the dark it starts fading. And just another example. And so in about 25% of patients it was difficult to identify scleral spur. With the newer machines it's much easier, so they perform quite well. So if we go back to thinking about risk factors, the traditional risk factors are around biometry, but it tends to be small eyes, big lens, hyperotropic refractive error, lens position. with the newer devices, we get more information, and it suggests most of what's causing angle closure is going on at the front of the eye. Now, people may tend to have small eyes, but often it's small and crowded anterior segments, and that might be due to the anterior chamber width and volume, the curvature and thickness of the iris, and the position of the lens, not just the size of the lens, but where it's positioned. And that's the lens vault. So the anterior chamber width is the scleral spur to scleral spur distance. And a smaller anterior chamber width seems to be associated with angle closure. And the lens vault is the distance between that line and the anterior surface of the lens. So it's not just the thickness of the lens, but where the lens is sitting in relationship to the scleral spur and iris. And there's a strong association between an increased lens vault and angle closure, shown in Asian eyes, and a relationship between the impact of taking the lens out, the degree of the lens vault, and the drop in intraocular pressure. So that's all supporting what we kind of know, which is the lens is important in angle closure. So how can we apply imaging to clinical practice? Well, we now at Moorfields, all our new patients will come through a virtual clinic where they'll come and have all the tests done, and those tests will be reviewed by one of the consultants. They'll decide whether they need to go into a clinic for a face-to-face assessment or can be discharged. And using the OCT to look at the angle is key to that, because if the angle's open and all the other tests are normal, we can discharge them. So it's got a great role there. We also use it more like a provocative test to confirm the diagnosis, or if we're unsure what's going on gonioscopy, or if we want to take the lens out, but we'd like to have some objective imaging that's recordable that makes the case for treatment. So this is just some examples of what comes through our new patient clinic. So this is showing very narrow angles, just a tiny slit open there. More open there, but still quite narrow. You can see scleral spur quite nicely. And this is showing definite iridotrabecular contact, a less steep curvature, but definitely showing ITC. And how does it influence our management? Well, management of angle closure is changing, so we're doing a lot less intervention anyway, but this is a patient who's relatively young, has iridotrabecular contact in 3 quadrants in both eyes on anterior segment imaging, and has a family history of acute angle closure. So all these would suggest they benefit from a prophylactic iridotomy. Whereas this patient has a narrow, but might be a bit of closure, but not too bad. ITC in 1 quadrant, is older and has early cataract. So you probably wait and see and take the cataract out if and when she becomes symptomatic, rather than do iridotomy. And we've recently done an audit of our new patients with narrow angles and what cutoff we should have for deciding if they need to go into the consultant clinic to have gonioscopy. And we found that if there is 1 quadrant of the 2 quadrants we measure on anterior segment OCT, which is nasal and temporal, of iridotrabecular contact, that agrees fairly well with gonioscopy and need for intervention in clinic. However, our indications for intervention are changing, so this will probably change as well. But we have refined down the reasons for referral from the virtual clinic to having at least 1 quadrant of ITC on anterior segment OCT. These are just some other clinical examples. So this is a patient with very advanced angle closure glaucoma, and in cross-section that's closed, but he's actually got PAS there, which you can sometimes see on the imaging devices, and that's useful to know because he's probably not going to do that well with a lens or cataract extraction with that degree of visual field loss and zipped up angles. So we did a trabeculectomy instead. This was a patient with recurrent subacute symptoms and high pressure due to angle closure. Not a particularly shallow anterior chamber. That's what I mean about the iris concertinaing into the angle and closing it off, and that these people typically get symptoms in dim lighting. And just when we took the lens out, you can see how much more it deepened, which you wouldn't necessarily expect with an already fairly deep AC. And we could discharge her after that. So I'll just run this video because it's a good example of everything. So you can see this is a young woman presenting with high pressure, and she's got a shallow peripheral anterior chamber. But the minute I looked at her, I thought, she's got a very deep AC. This isn't pupil block. And she presented with high pressure and visual disturbance. And we did iridotomies, but kind of suspected that wasn't going to really work. You can see she's got peripheral anterior synechii there and quite a flat iris contour. Areas you can see the pigmentation which are open, and there you can see the apex of the corneal wedge. This is a Caucasian woman. It's quite unusual to see this sort of presentation. Quite advanced angle closure with extensive PAS in our Caucasian patients. And she had very advanced disc cupping as well, which you'll see. So we did some anterior segment imaging, and there you can see the cup disc. And again, quite deep, and with iris cysts, which is probably what's contributing to the angle closure. So another unusual patient we saw one Christmas, sudden onset blurring of vision, youngish, came into A&E, angle closure, high pressure, both eyes, and a myopic shift. This was actually done when he was getting better, but he's got these effusions. So this is the type of atypical angle closure you can see with certain medications like topiramate. He wasn't on any. We saw 2 or 3 more patients like this that winter, so I wonder if it was some kind of post-viral thing. But he resolved, so you give them atropine, support them through their myopic refraction, and then he was better after 10 days. So the anterior segment OCT was quite useful there. So in summary, advances in imaging allow us to better identify angle structures and help us evaluate the mechanisms and risk factors, and give us accurate dimensions which are useful in research, correlates well with gonioscopy. We still think it's a good idea to do gonioscopy to visualize the angle and PAS. And I would say more than being used in screening, I think anterior segment OCT is quite useful in the era of non-contact ophthalmology, which we're entering at the moment. And we're certainly putting a lot more of our patients through our virtual clinic, and it has a key role there. So I'm sorry I've run over slightly, but happy to take questions if necessary.
So, Nolan, thank you very, very much for this excellent presentation and talk. I'd just like to start with a very simple question. Looks very basic, but just for the audience. We started by making a clinical examination of the anterior chamber with the slit lamp before gonioscopy, the Van Herk method to check the peripheral depth of the anterior chamber. I just would like to stress, or you would like to stress to the audience, that this is just a screening and it is not a replacement for classical gonioscopy. Gonioscopy is a must. We just screen the peripheral anterior chamber. Am I getting this message correct? This is not a substitute for gonioscopy.
Yeah, that's correct. I mean, the people who would use it in the UK are our optometrists, who people go to get their glasses from. And then maybe if patients are coming through our A&E department, you might pick up some of that. But generally, it's the optometrists will refer to us based on the Van Herk. So it's a method of case detection, which, as you say, needs to be followed up with a definitive angle examination.
Now, following on this same line, the excellent anterior segment imaging that you demonstrated, and you've mentioned that you're using now virtual clinics in more fields. So to what extent would you rely on the anterior segment imaging for referral of patients to actual face-to-face meeting in the virtual clinic? In other words, I want to say, is the virtual clinic run by only anterior segment imaging with no clinical gonioscopy? So then would you rely, that means that you rely only on anterior segment imaging for deciding whether this is a need for a true meeting, a clinical meeting with a glaucoma specialist or not?
Yeah, I mean, obviously we're doing intraocular pressure, visual acuity, fields, and disc imaging as well, so, and a history. So, but from the point of view of the angle only, if all the other tests are normal and the angle is open, we discharge. So the only reason for referring in just for an angle examination with other tests normally would be on the anterior segment OCT if we were seeing iridotrabecular contact.
Okay, so we can rely on anterior segment imaging for deciding whether a meeting with a glucomatologist or not.
Yeah.
Okay, so now we have a question here, Ms. Nolan. We're in the era of telemedicine, of course, and again, speaking of non-glucomatologists seeing patients for the first time. So there's a question: are there any tips to photograph the angle during gonioscopy using mobile phones? Any tips that you know? I mean, now our residents take photos from the slit lamp with the mobile phones. Is there any tips for gonioscopy that we have this question?
I've never taken pictures with a mobile phone. Those pictures that you saw there are all pictures I took when I worked in Singapore, and
with the digital photo slit lamp, of course. I know,
yeah.
not with the mobile.
Yeah, from the slit lamp, but it wasn't with a phone, and I must have used a camera on it. But one of the things I'd say is you need to use quite bright illumination to get a photo, so much brighter than you would do true gonioscopy.
And stability a little bit. Any movement would distort the image, I think so.
Yeah, and I think you need to use the MagnaView. So those would be the tips: the MagnaView and illumination, but a narrow beam, so you can get that visualization through the structures of the angle. Sure.
Okay. So it's better still to rely on fixed equipment rather than cell phones for the time being.
Well, I've never tried it. It's just difficult because you've got to get everything in the right place, and ideally, if I don't know quite how, whether you'd be viewing it through the phone, maybe that works. But it's not that easy to take gonio photographs, to be honest.
Okay, so let's take one final question is simply, how would you judge an angle to be, which structure would you visualize to judge an angle as open or closed to the extent that would need intervention, whether iridotomy, lensectomy, whatever?
Yeah, so I would say if I can't see the trabecular meshwork, which is posterior to the Schwalbe's line, so if I can't see Schwalbe's line, or I can't see behind that, it's closed. Because
if you can manage to see any of the trabecular meshwork, it's okay.
Yeah, in primary position without manipulation.
Okay. So thank you very much, very much, Ms. Nolan, for this very informative presentation. And thank you very much for answering the questions of the audience. And we would then move to our next speakers. Okay, they're asking me to raise my voice. Okay, so thank you. Okay. So now we have the honor to proceed with the next part of our webinar today, which is discussing intraocular pressure measurement. We start by our dear colleague from Cairo University, Dr. Reham Samy, that will talk to us about Goldman affiliation tonometry, the gold standard, of course, pitfalls and basics and pitfalls. So please, Dr. Reham, take the lead. Thank you. Reham, are you with us?
I think, Dr. Reham, the mic is off. Please unmute. Okay, go with the movie, please.
All your beloved ones.
Okay, do you hear me like this?
I'm going to talk about dry eye patients, especially who is associated with age.
I'm muted, Dr. Ahmed.
Solution from Orca-P-Post and PolyFresh Extra. Orca-P-Post is anti-aging and anti-allergic agent, which is not only has exceptional antihistamine effect, but also has a novel special mechanism as anti-aging agent by inhibiting nitric oxide secretion at nerve endings. The second arm of our solution is PolyFresh Extra, which is a new combination that gives extra hydration effect and balancing the tear film osmotic pressure, in addition to the anti-inflammatory effect of glycerol. Thank you for your time.
Okay, now
Reham, please proceed.
Okay. Okay, is my voice clear now?
Perfect.
My talk is about Goldman applanation tonometry basics and pitfalls. We all know that intraocular pressure is an integral part for the diagnosis of glaucoma. Sometimes we ask ourselves what's the real intraocular pressure, particularly when dealing with a suspect with a borderline pressure or a patient who is apparently controlled but still progressing. Starting from the very beginning, glaucoma has been known to be a blinding condition since ancient times. However, it was described in the 19th century, the effect of intraocular pressure, when William Mackenzie and Demers noticed that glaucomatous eyes are firmer than healthier eyes. This was further translated by Van Grief and Donders into measurable effect. They tried to measure and quantify the intraocular pressure using transscleral tonometers. Still, we are with the prototype applanation tonometer invented by Alexei Maklakov in 1885 after the invention of topical anesthetic. And this applanation tonometer was performed when the pressure was lying in the supine position, and there was a conversion table that takes a reading from the stained foot plate of this applanator and converted through a nomogram into an intraocular pressure. What we know about applanation nowadays is still the gold standard. It's the one which is invented by Hans Goldman in 1954, and it is like trabeculectomy, still living and still surviving as a gold standard for intraocular pressure measurement. Simply, it is based on a mathematical formulation known as the Embert-Fick rule, which states simply that when you want to quantify pressure inside a thin-walled sphere, you can just measure the pressure need to flatten a fixed surface area of this sphere. So simply pressure equals force over area. However, in our eyes, we still have extra forces because we have the surface tension of the tear meniscus, which adds to the tonometry probe force effect, as well as the corneal viscoelastic properties, which offer resistance to applanation. So Goldman, after meticulous work, he concluded that these two forces are negligible when we have a fixed surface area of a circle whose diameter is 3.06 millimeters. At this diameter, these two extra forces are cancelled, so we come back to the original law, pressure equals force over area. So we still have a circle that we cannot manipulate. So we have to divide this circle into two halves and then to come to an optical endpoint. And so we have to have something that splits light, which is the optical prism. And this optical prism split this surface into two hemispheres in order to manipulate these two hemispheres to reach an optical endpoint, which has certain criteria. One of them, which is that these two halves touch each other from the inner side, just touching each other, with a nearly width of nearly 0.3 millimeters. And then we can get the measurement of the pressure from the dialing knob by multiply the number on this scroll by 10, or in newtonometers, just reading off from the digital applanator. Okay. Then, as we said, this is the probe of the applanation, and it is mounted on a slit lamp, and we will find the endpoint by having these two circles. Again, we have another confounder, which is the tear meniscus around the tip of the applanation itself. So to differentiate these two menisci, we have to stain the tear meniscus in order to have a clear-cut edge point, which is by using the cobalt blue filters in addition to fluorescein. And so we will have a clearly demarcated yellow marks that fluoresces with the cobalt blue and can get a near estimate of the intraocular pressure. Okay, we have to bear into our minds that we are dealing with a tonometer. It gets a reflection of the intraocular pressure. It's an estimation. We are not having a manometer that is inserted inside the eye to get the actual intraocular pressure. So there should be some sources of errors while dealing with this applanation. And in order to see how huge or how numerous are these sources of errors, this is very hectic. So we can simply divide them into something related to the technique of applanation, or something related to the patient himself, the factors inside the cornea of the patient, the factor inside the patient himself. So don't be overconfident while applanating your patient unless you resolve these errors. One of the sources of these errors is the area of tonometer tear film contact. We have the tear film meniscus and the applanation tip or the probe just touching the interior surface of the cornea. This, in order to obtain this well-defined adequate marks, we have to have an area of contact which is not too excessive when we have a tearing patient, for example, or excessive fluorescein, because this leads to overestimation of the pressure. Or we don't want to have insufficient tonometer tear contact with which the fluorescein will not be very apparent, and so we will get an underestimation of the intraocular pressure. Another source is the duration of tonometer to eye contact. When you put the applanation over the eye, you should not exceed in your measurement half of a minute, because if the pressure of the applanation still is exerted on the cornea, we have a decline of the intraocular pressure or an underestimation of the pressure, probably due to the mechanical effect of the probe itself, sometimes due to vascular causes, which is seen in tense patients, or due to accommodation exerted by the patient if he looks just to the applanation. We usually instruct the patient to look away in order to avoid this. Or another thing related to the corneal viscoelastic material, which is known as corneal flowing. By the prolonged contact of the applanation to the cornea yields, and thus underestimation occurs. Another source of error is the illumination of the tonometer head. Actually, this is well seen in the old versions of the Perkins tonometer. However, if the tip of the or the tip of the cone itself is not well illuminated properly by adequate increase in the slit lamp power or the slit lamp voltage, as well as proper putting the angle between the applanation and the illumination beam at 60 degrees in order to shine the cone properly. This is another source of underestimation of the intraocular pressure. As I said before, that adequate fluorescence of the tear film is important for near accurate intraocular pressure estimation. Some authors wrote about doing applanation without fluorescein, and this in literature leads to underestimation. However, this underestimation was calculated in the normal range of the pressure to be from 2 to 5 millimeters mercury. However, this relation is not linear and it gets fallacies in extremes of pressure. The concentration of fluorescein, usually we use a fluorescein of 0.25% if we use the highly concentrated fluorescein strips, but sometimes the commercial fluorescein strips are not so concentrated. This gives an underestimation. Also, we use topical anesthetics like binoxynate, and fluorescein usually loses its fluorescence in acidic media. And so there is quenching of fluorescein. And as I said before, there should be good illumination. Another major source of error is our target tissue, the cornea. The cornea itself is a major problem while we are dealing with the applanation. Either if the cornea has got an abnormal structure or an abnormal shape or abnormal curvature. We all know that the average normal central corneal thickness is around 520 microns to 540 microns. The Goldmann applanation tonometry is well calibrated for the 520 range of corneal thickness. However, this is not the normal range of our population. So studies have got an estimation that for every 10 microns difference from the normal, we should adjust the intraocular pressure. The thin cornea gives an underestimation of the intraocular pressure, so we have to add to our measurements. While on the reverse, the thick cornea, like those in corneal scarring, for example, can lead to overestimation of the intraocular pressure. So we have to bear into mind that pachymetry is an important part or an integral part for proper intraocular pressure estimation. Also, we can find some patients having corneal edema, and this is important post-operatively. When we evaluate the pressure in cataract, for example, if we have an edematous cornea, we have to bear into mind the corneal edema attenuates the intraocular pressure. So we measure it falsely low. So we have to add to our measurements also. Regarding the effect of corneal curvature, steeper corneas need to be indented more in order to get the proper circles as we saw before. So the steep cornea tends to get a higher IOP or overestimation of the pressure. This is seen in corneal astigmatic errors. So why does this occur? Because when we have a uniform cornea, we have a proper circular pattern or a proper circle or a proper sphere, which we bisect into two hemispheres. However, when we have with the rule or against the rule astigmatism, this sphere becomes an ellipse. So the area of contact between the tonometer and the cornea is not that we are assumed to know, or for the Goldmann applanation tonometry to get proper readings. While in irregular astigmatism, we acquire distorted Meyer, so sometimes we cannot applanate this as in post-PKP patients. Now, how to adjust this? In cases with regular astigmatism, it is estimated that for each 4 diopters of corneal astigmatism, there is an error for the intraocular pressure of 1 millimeter mercury. To understand this, they found that patients having oblique astigmatism of nearly 43 degrees do not have this problem. So it was postulated that if we adjust the tip of the applanation, we have here 2 marks, the red mark and a white mark. And this red mark is to be put on the minus axis of the patient, the minus axis of the autograph, and not the flat K. By which I mean that we put it in the minus axis of the autograph or the flat meridian of the cornea. If we adjust this, the white mark automatically is set at 43 degrees from the horizontal meridian. So the sphere, the round sphere which we see in this position will be converted to be in this position, as we see in this image. So the ellipse is retransformed into a sphere, and we can get a true intraocular pressure. Other factors that can lead to over or underestimation of the pressure is the blepharospasm. If you have a tense patient, you have to relax him. He has to open both his eyes. Sometimes we can aid the patient by pulling the 2 lids away, but beware not to put your fingers over the globe itself so as not to overestimate the pressure. You can put them over the orbital bones. Repeated disaffection of the tonometer tip can result into some cracks that can lead to errors in the applanation tonometry. Arterial perfusion pressure induced by carotid compression can lead initially to lowering of the intraocular pressure, and also patients wearing tight collars can have an increase in the central venous pressure with overestimation of the IOP. Another source of error is applanating a paracentral cornea or an off-axis applanation. Usually we put the applanation onto the central cornea. This is the target. However, sometimes the applanation is rotated to have the paracentral cornea. If you have a central scar and you want to get an estimate of the intraocular pressure, sometimes you get a little bit paracentral, or that the contact between the applanation is not complete with the central part of the cornea. If this is within 5 degrees, this will not induce a significant error. However, if it exceeds this, a significant error in the intraocular pressure will be taken. Another thing or another important source of error is the presence of restrictive ocular disease, like patients with dysthyroid ophthalmopathy. This is known as differential intraocular pressure. We measure the intraocular pressure in the center, and usually if the patient looks up gaze or down gaze with a free motility, the difference between the measurements does not exceed 5 millimeters mercury. If this is evident, this patient can have a restrictive myopathy. An important forgotten source of error in applanation tonometer is the calibration of the tonometer. And I don't know how often do we check the calibration. Usually we check the calibration when we get errors. Actually, we have to check it at least twice per year or once per year. And this is done easily with the calibration bar or the calibration weights. And this calibration bar, for example, is set at 0, 20, and 60, and you put it at the 0 position and put the knob in the same position, and then this bar is straight and there is no movement on the applanation tip. When you move this, rotate this knob 2 millimeters or 4 millimeters above and below this number, you see a movement or a twist or a spring in the applanation tonometer itself. If any error in calibration, it should be returned to the manufacturer for maintenance. So these are the pitfalls in the applanation procedure itself. However, I would like to highlight some pitfalls in intraocular pressure practice. Number 1, tonometry is part of the routine examination. Some people, I don't know from where is the concept, do applanation only or tonometer only for patients who are suspects or patients above the age of 40. Actually, we can sometimes spot glaucomatous patients at the age of 20s, and unfortunately, these are fast progressors. So do not rely that you see cupping, then measure the pressure. You have to measure the pressure for every patient. Do not rely only on some screening tools like the air puff. The air puff is only a screening tool. When you spot a high pressure with the air puff, you should repeat it again with the Goldman applanation tonometry. Pressure before contacts. Please do pressure before anything contacts the eye of the patient. Just like Dr. Nader mentioned, gonioscopy is part of the routine examination. You should not perform pressure after you perform a gonio, or you will take a false low estimation of the intraocular pressure by the massage effect of the gonioscopic lens itself. Do not treat any patient with a pressure just because it is above 21. You have to properly investigate, is he glucomatous truly or not? A single pressure reading is not sufficient. Sometimes you have to understand that the patient can fluctuate over the day. So if you have a glaucoma suspect, you have to pay these intraocular pressure. As we mentioned before, take refractive errors into consideration, not only astigmatic error, as I mentioned, but also myopic patients. And myopia and glaucoma pose a challenge in either or, because of the central corneal thickness, because of the elastic properties of the myopic eye, which is known to be a fragile eye, or because of the incidence of refractive surgery done among myopes. And so take biomechanics into consideration. Biomechanics, corneal biomechanics are intimately integrated into every step in glaucoma, from the pathology to the treatment. And then we have some machines that can take a compensated intraocular pressure, whether the Aura or the Corvise. This is an example of a patient who presented to me performing LASIK and complaining of headache. I measured the pressure, it was 14 and 17 at 4 o'clock p.m. And then I repeated the measurement on the second day, it was 21 at morning and 28 in the other eye. And this is the cornea compensated pressures, they are approaching 30 and exceeding 30 in the other eye. So this patient is glaucomatous, but might be missed due to only relying on the applanation without taking into consideration the biomechanical facts. So the sources of error, to summarize in GAD, can be related to the technique, the area of the duration of the contact of the applanation tip, fluorescence and illumination, and something which I did not mention, which is the magnification. You have to be sure that you are set on the magnification of ×1 or ×10, because sometimes some residents fell into the mistake of putting it on the high magnification and failing to get a proper intraocular pressure. The cornea, which is an important target for applanation, you should take into consideration abnormalities in shape, presence of astigmatism, structure and thickness. The calibration should be checked once a year or even twice per year. Other things like the off-axis applanation, blepharospasm and differential IOP. Some pitfalls during IOP practice, just I mentioned, tonometry is a part of the routine examination, pressure before contacts, take refraction into consideration, as well as biomechanics. Never treat a patient because just he has a pressure of 21 or more. Do not rely on the air puff. A single pressure reading is not enough. And thank you for your attentive listening.
So Reham, thank you very, very much for this excellent presentation that is not only practical, but also evidence-based. We really thank you very, very much for this. And we have a question from the audience. Is there any, would you consider anything different if you have a hyperopic astigmatism or if you have a myopic astigmatism on the cornea? I mean, would you adjust the red mark on the axis of the minus cylinder, and irrespective of whether this is a hyperopic or a myopic astigmatism?
Yes, yes, I might not have clarified this point. You put the applanation on the minus axis of autograph. Just as this corresponds to the flat meridian of the cornea. Regardless, this is a hyperopic or a myopic astigmatism. Do not complicate things.
So it's just the flat meridian and that's it. There's no problem which type of astigmatism on the cornea.
No, you have to adjust it just to put it on the proper axis.
Okay, thank you. Now, the next question would be the cutoff value of the central corneal thickness, the CCT in the applanation. I just missed the figure. Is it 520 or 542 microns?
It's written in literature in different ways. Some people write that it is 520 and others it's 540. So we have to take the normal range of our population, which is nearly 520 to 550 or 540. And then every 10 microns above or below, you have to adjust the pressure. There are also nomograms that are set for this because the higher the difference in thickness, the non-linear the pressure is. So this is such a rough figure to be able to convert the pressure.
And even so, a 20 micron difference would not mean much of a calibration error, just 1 or 2 millimeters mercury.
It's 1 millimeter, which is not the diagnostic way.
Okay. One last issue, could you explain to our audience just how would an increased corneal thickness from corneal edema result in a falsely low IOP measurement?
Yes, this is not related to the thickness itself. This is related to the corneal properties as well. The cornea yields with the applanation, so you need less force to flatten it, and so the pressure is low. It's not related that the cornea is thick. The cornea can be thick but edematous, like in the pus and like in the pseudophakic bullous keratopathy, for instance.
So it would absorb the pressure of the tonometer.
Sorry?
It would absorb the pressure of the tonometer
Yes,
tip.
it will attenuate it actually, yes. You need less pressure to flatten this.
Okay, and then our very famous question, any recommendations for IOP measurement after refractive surgery? Our biggest hurdle.
This needs a meeting actually. I will tell you my practice. I usually take a baseline aura exam for the patient. And I usually phase these patients to pick the moment of the intraocular pressure peak. When I take a single reading for the cornea compensated pressure, I can tell arbitrarily the difference between it and my Goldman. And then I repeat the aura semi-annually in the first year and then annually later on. But this is not an evidence-based, this is a personal practice.
So refractive surgery still remains an issue with measuring of the intraocular pressure.
Yes. Yes.
Sure. So we thank you very, very much repeatedly, Dr. Reham, for this excellent presentation. And let's move on with our last but not least presenter, Dr. Amanne F Esmael, to talk to us about indentation without tonometry. So Dr. Amanne, please take the lead. Very clear. The presentation, Dr. Amanne. That's it. Done.
Okay, now you see it. Great. First of all, thank you to all participants for staying us till the end. And thank you, Orchidia, for organizing this meeting. And definitely thank you, Professors Khalil and Bayoumi, for this kind invitation. This presentation focuses majorly on the practicality of indentation and rebound tonometry in our clinical practice. So there isn't much details, but a comprehensive display. As we have seen, Goldman applanation tonometry is the gold standard. However, present in our market and in our practice are a group of instruments that are based in their function on the principles of indentation tonometry or rebound tonometry as a sole mechanism, or a combination of indentation and applanation, applanation tonometry combined, like the tonopen and the pneumotonometer. So what is indentation tonometry? Indentation methods actually measure the depth of corneal indentation made by a given weight. So the force or weight that will cause more indentation in soft objects as compared to harder objects, it will give less weight or give less indentation. So the most commonly present right now, either the pure indentation device as shots or combined indentation and applanation, as I mentioned before. Shots has been ruling the field of the intraocular pressure measurement in the first 3 quarters or so of the 20th century. And it is a very simple device, easy to use. It has a plunger that is encased in a barrel, and the barrel has a foot plate that is concave and rests on the cornea. As the plunger moves, its movement is transmitted to a scale through, the movement is transmitted to the needle, and this gives us a number on a scale. Several weights can be mounted up here, so to be used for different measurements, especially with the higher intraocular pressures. So the amount of indentation is indirectly proportional to the intraocular pressure. So how do we perform it? First, we have to calibrate the device, and there is a little metal present in the box where you can use it for calibration, then sterilize the device, instill topical anesthesia. The patient should lie on their back, and you instruct them to look straight ahead to avoid accommodation. And then you hold the instrument perpendicular to the corneal surface. You get a number on the scale and you move on to a conversion table and see what intraocular pressure is written opposite to that number. And usually the recording should be recorded as follows. You should name the number that is present on the scale, the weight that you've been using, the intraocular pressure that is indicated in the conversion table, the version of the conversion table, because there are two conversion tables present, and they're both developed by Friedenwald, one in 1948 and one in 1955. And definitely you have to state which eye. Indentation tonometry by Schiotz could be considered cumbersome by some, as the patient needs to lie supine. There is a risk of corneal aberration if the patient moves and doesn't stay still. And serial attempts displace aqueous humor and may cause a false lower reading. However, we should not forget that Schiotz tonometer is affordable and robust. It doesn't have any complicated electronics involved. It is suitable for screening, especially in the low resources areas and remote settings. So why is Schiotz not used right now as applanation tonometry or the Goldman applanation tonometer? It has been well established since 1965 that applanation tonometry gives more accurate information about the intraocular pressure. And several studies have shown that the discrepancy between both devices' readings can be as large as 5 millimeters mercury or greater. And usually Schiotz tonometer, in the majority of cases, will give an underestimation when compared to GAT. Additionally, scleral rigidity plays a huge role in the measurement of intraocular pressure by Schiotz tonometer. So you got to be very, very cautious in ophthalmic eyes in patients with high errors of refraction on the both extremes of the spectrum, in microphthalmos, vitrectomized eyes, and in the presence of cornea scars. Cornea scars can give you false readings on both ends, and depends on whether the scar is hard or the scar made the cornea weak. So, in summary, Schiotz tonometer can be used as a screening tool, especially in limited resources and remote areas. Other indentation tonometries include the tonopen and pneumotonometer. The tonopen is another portable handheld device that is lightweight and easy to use. And additionally, you can use it either in the upright position or in the lying down position. But you have to remember that the force used to determine the intraocular pressure by this device is based on empirical studies. And hence, the device itself will take multiple readings for you and display an average with a standard deviation to give you a clue whether to take this reading into consideration or not. However, it only requires a small contact area, so it is very useful in people with having an irregular corneal surface, and it provides reliable measurements in situations like wearing therapeutic contact lenses. Studies have shown that the intraocular pressure measured from while the therapeutic contact lens is worn or without it, the difference is quite slight. So the tonopen limitations include that it over and underestimates intraocular pressure in correlation to GAT, and still, again, just like GAT, central corneal thickness does have an impact or an impact on it. However, studies have shown that this impact is around 0.74 millimeters mercury for each 10 microns. On the other hand, the pneumotonometer contains a silicon tip measuring around 5 millimeters in diameter at the end of a floating piston. And the tip is used to gently indent the cornea or flatten the cornea, and through a controlled flow of air. The pressure forcing the tip ahead when the tip and the cornea are both flat and in equilibrium is used to provide us with the intraocular pressure measurement. Again, it's a portable device, easy to use, with minimal contact to the cornea surface, which makes it useful for screening. However, it's quite difficult to disinfect its tip. It still requires a topical anesthetic. Calibration is essential, and it might underestimate or overestimate intraocular pressures. It underestimates at the lower values and overestimates in the higher values by most studies. And again, central cornea thickness affects its reading. So in total, most of the indentation tonometers might be suitable for screening and might have a special role or an upper hand to GAD applanation tonometry in situations of limited resources or remote underdeveloped areas, or in the case of tonoplan in irregular corneas or in the over-therapeutic contact lenses that cannot be removed. Now, the second part of this presentation is considered with rebound tonometry. And the principle in rebound tonometry is that a moving object, when it hits a stable object, it will decelerate. And what rebound tonometry does is that it measures the speed at which the moving object or the probe of the instrument decelerates at. So if you are confronted with a high intraocular pressure, the deceleration will be rapid. And if you're confronted with a low intraocular pressure, the deceleration will be slow. The rebound tonometry has been long introduced since 1997, probably that's not long. And the first device is produced by iCare was the TA01. However, there's an array of devices with different advantages in correlation to each other. So how does it work? You have a stainless steel wire that is held in place through an electromagnetic field. And this stainless steel wire ends up in a plastic segment that ends up in a small ball that has the diameter of 1.8 millimeters. Pressing on the back button of the device will cause this wire to move forward. A spring drives the wire and the ball forward rapidly, and as it hits the cornea, it decelerates. The speed of deceleration is measured and converted by the device itself into an intraocular pressure reading that appears on the display screen at the back of the instrument. How do we take measurements? The advantage of this device is that it doesn't require topical anesthesia. However, you need to hold your device absolutely at right angles with the cornea. You instruct your patient to look straight ahead, and you need to keep it at a distance between 4 and 8 millimeters. A distance that is further or closer to the cornea will not give you readings, and also tilting of the device. So what are the pros and cons of rebound tonometry by iCare? The device is a handheld device, lightweight, portable, doesn't cause patient discomfort, being so small, and it doesn't need a topical anesthetic or a fluorescein dye. The small probe also is very useful in people with small palpebral fissures and in really small babies. So all of this makes it a very valuable screening method. With the old models as well, the measurement doesn't have to be precisely at the center of the cornea, which gives it an advantage in measuring intraocular pressure in children. And also the availability of home models can reduce the load on clinics, especially in our times when we need to do things a little bit remotely. However, the disposable probes that are used, each causes a US dollar, which might be expensive in areas where there is a low income parts of the world. The older version also requires measuring only in the upright position. However, you can come around it by making the patient lie down on his or her side. And the major issue is the variable reports about its agreement with the Goldman applanation tonometry. So most studies have shown that contradictory results, both in terms of the tendency and the limits of agreement. Sometimes the reports would say that rebound tonometry overestimates. Sometimes they say it underestimates the intraocular pressure when compared to GAD. And there is a wide range of limits of agreement between both devices. Most studies have attributed this to the variation in the age groups of their populations, and attributed this also to corneal biomechanics as the corneal resistance factor and corneal hysteresis, and also whether the patient is accommodating or not. The good news is that newer models tend to show more agreement between both devices. However, there's a problem with the newer models is that they have a positioning sensor, and hence it's not easy to use them like the older model in children. So again, it's a very useful screening device. In the end, I just want you to remember two things, that indentation tonometry measures displacement, whereas the rebound tonometry measures deceleration speed. And that none of the above mentioned devices could yet replace GAT with all its limitations as well, because none has shown a universal and standardized correlation with GAT. However, they can all be used for screening, and while putting into consideration the available settings and the kind of patients that we have. And in given situations, some of them are more appropriate than GAT, for example, in bedridden patients. Finally, remember, again, as Professor Alem has kindly said, IOP is merely a number and should never be the sole factor in determining whether a patient is glaucomatous or not. Thank you very much for your kind attention.
Dr. Amanne, thank you very, very much for this excellent presentation. A touch from the past and a look at the future. That's really great. So, are we still there? Okay. Now, I have just one simple question to Amanne about the rebound tonometry. What about the disinfection? Is there any, are there any literature or any of your personal opinion about the disinfection of that tip? It's disposable. So it's disposable, single use and thrown away, no place for disinfection.
Yes,
I get this message right?
Yes, yes, and that's why it is considered costly.
It's considered what, sorry?
I would consider it costly in our setup.
Okay, okay,
It
and
would
the
be
advantage
considered
of the
costly in a setup where there is a, the majority have low income.
Majority have, sorry? Unmute.
In low income countries,
yes, I
it
got
would
it.
be considered costly.
I got it. Sorry, I couldn't hear you. I'm sorry. Thank you very much. Okay, so we have this question. What would you think the most proper way to measure the intraocular pressure in children?
Actually, since I'm working in the field of pediatric glaucoma,
Yes,
usually we measure the intraocular pressure using a handheld Perkins applanation tonometer. In some children, you can really measure their intraocular pressures while they're spontaneously sleeping, especially the small ones. However, after the age of 6 months, we give them chloral hydrate, we sedate them, and we measure the intraocular pressure. If this is not possible, then examination under general anesthesia is done with its precautions, because you know the effect of general anesthesia, as it deepens, it lowers the intraocular pressure still. But again, an intraocular pressure should not be your sole determining factor.
Sure, we just want to know how to measure it accurately. Okay, one last technical question from me personally. The rebound tonometer, the rebound tonometer itself, can you hold it face down, or that probe would fall down? I don't have experience in using it.
No, the iCare Pro and the IC200, you can use them in supine patients. It's the first model, the TA01, that you cannot hold it downwards. You will have the patient has to be sitting upright or lying on his side, and then you will.
And you use it still horizontally. So
yes, you will be vertical.
Yes, I know. My question is, does this new instrument compensate for the effect of gravity? Yani we all know from our study of physics that gravity accelerates any free fall of any object. So if the patient is supine and I'm using the instrument in the face down position, the instrument is looking down. The gravity would accelerate the.
I'm not so sure I have a straight answer for this, but I think it's held in its position by an electromagnetic field. I guess
That's a good point of that's a
would
good point of
need
a study, or asking the manufacturer, Dr. Amanne, does the gravity, does the instrument compensate for the acceleration induced by gravity effect on the free fall if it is held in the face down position or
I
not?
don't
It's
know.
interesting. It's an interesting question. I will be very interested to ask that
Yes,
question.
I don't know. It's quite
Hey,
a good question.
thank you. Thank
Mind
you very
teasing
much.
question.
Thank you. Thank you very much, Dr. Amanne.
Thank you very much.
So now, arriving at the conclusion of our set timing, I would like to repeat our gratitude and thanks to our panelists, our speakers, Dr. Amanne from Cairo University, Dr. Reham from Cairo University, Ms. Nolan from Moorfields, and our Honorable President, Professor Ahmad Khalil. We would like to thank Orchidia for their continuous support and for organizing the technical part of this meeting, and I would conduct and leave the mic to our professor, Professor Ahmad Khalil, or to Orchidia to conduct this webinar, to conclude this webinar, sorry. So thank you very much. Goodbye.